Annie Sue, who's going to take us through this next session. I also want to thank ConMed for sponsoring this session. Annie, it's all yours.
All right, thank you. Good evening, everyone. It's a pleasure to join everyone today to talk about our second session, and our topic will be ankle implants and masks, looking at the long-term durability, the functional results in survivorship, and really looking at different various type of total ankle implants. I am joined by three esteemed speakers. I think two are having some technical challenges. So we'll start off with Dr. Scott Ellis. He is a very well-known figure in our ALFAS society, and did his residency and fellowship at Hospital of Specialized Surgery and stayed on and continued to practice there today. Thank you, Scott.
Yeah, I made it easy because I just never left. I'm boring. Thank you, Annie, for putting this together and for all the work behind the scenes. And thank you again to Celine. All right, so here we go. So, part of what I want to talk about is just, and some of it came up in the last session, was the future of total ankle as far as what have we learned so far with mobile versus non-mobile bearing implants, and what does that really hold for the future? I had studied this and given a version of this talk previously and capitalized on some of the work that Andy Goldberg was doing. So special thanks to him. You'll see some slides of his here. He's going to be one of the at least moderators on one of the upcoming sessions too. So it's nice to again see how everybody from around the world is just coming together. Just a few disclosures I think that are important. I know it's not necessarily like our CME stringent as these other talks we give, but I do consult for Stryker, and I am going to show some implants, although really what I want to do is compare mobile versus non-mobile bearing implants is to cross all the implants that have been designed. These were Andy's disclosures as well. Total ankle, as its past and its future, is an evolution like we just discussed in our last session. Everybody has their own journey. It was funny because Andy put these pictures together, and for those of you that have been around a while, you'll know a lot of these faces, some of you through fellowship. A lot of these are people that helped design and push total ankle forward. This is my journey. Again, as Andy said, it was from the Hospital for Special Surgery. I did have an opportunity right after fellowship to travel and study total ankle. The left upper picture, actually the left upper two, are from Lyon, France, where I went to visit Michel Bonan right after fellowship. And he had been one of the designers of the Salto implant, which is a mobile bearing version of the Salto Talaris that we have in the United States, which has given us a unique opportunity to look at mobile versus non-mobile bearing. The picture on the lower left was actually part of our flat foot consensus, but some experts there also, including Beat Hinderman and Luchon, who have designed total ankle implants, and I've learned a lot from them, and some of my other mentors on the right from special surgery. But it's a journey, and Steve Haddad too, who, as we know and was mentioned last talk, has done so much in total ankle. This is Lyon. This is actually a picture I took during that fellowship time I was there. It was beautiful. I almost contemplated never coming back to New York, but I did because, like I said, I could never leave. Casey talked in the last session very nicely about the evolution of total ankle implants, and it's amazing. I think even in the U.S. now, she showed we have 9 or 10 that are currently available. We've come so long. All these you can think about are either mobile or non-mobile bearing. There's some examples on the left, which is the Agility, the Salto Talaris, which is the non-mobile bearing, and the Imbone. All those, and in large part, the ones that we have available in the U.S. are non-mobile bearing. And you have a version of the Star on the right, which has been around for a long time as well, which has stood the test of time. That's a mobile bearing. Andy showed pictures of a number of different mobile bearings in his talk as well. And for those who don't know, maybe I should take a step back. In the mobile bearing, the polyethylene is free to move with respect to both the tibia and the talus. Now, it generally has a flat articulation with the tibia on the above, and a congruent articulation with the talus below. A lot of these have the sulcus geometry that you can see here. One of them is a Hinderman implant. You see the Star there. There's a couple others I never had a chance to use, but the AES system and some others that have been used in the past. This is Dr. Kofed with a quote on his design of the Star implant, which stands for the Scandinavian implant, but just saying how the evolution of the total ankle has just been it's been an effort over time, trying things that work and those that don't, and just capitalizing on experience and outcome data. Again, this is what Casey Humbridge showed. I don't need to go over them all, but there was a first generation that was highly constrained, mostly implants from other joints that had been adapted, which failed. The second generation really was what allowed us to get where we are now. Implants that you might recognize, for those of you that have been doing it long enough, are the Agility, the Star, and the Buccal. Of those, the Agility was the only fixed bearing. So there's still at that time more available that were mobile bearing. Casey again showed the Star. I don't need to go into great detail, but it's been used worldwide for many years. And the idea again is that polyethylene moves. There are different iterations of this, one with the tibia component being plastic or polyethylene only. And as things evolved, that changed as well. That implant has been really important in our country because there is a special FDA approval process because it was not predicated on a previous fixed bearing implant to be FDA approved. And this is the pivotal trial that came out, which really showed it was non-inferior to our ankle fusion and allowed us to use that implant. FDA approved. Pappas and Buccal I always find interesting because they're not too far away from, or we're not too far away in terms of practice from New York City where I'm at. I have patients to this day that had their implant that still come in and see me occasionally. And even though we don't use the implant, it actually was pretty successful. The implants improved, and over the third generation, we saw improvements in the Agility, which was developed the LP. That Salto Talaris was the fixed version of the one I showed you from France. As Rishan noted in the last talk, the Inbone came around 2005. There's the Inbone 2 that came probably 8 or 9 fixed, in the Eclipse, which I'm not real familiar with, was very used at just a few centers. Just some key design features. This is a Salto Talaris, which had that barrel fixation, different radius of curvature for the medial lateral aspects of the talus, and it had a tibia that would self-center itself before you drill that keel. The Inbone, I think a lot of people know of and historically was thought of as a revision implant, was modular, has really stood the test of time, and again is non-mobile bearing. And I didn't say this, but non-mobile bearing means that plastic is clipped into the tibia. Okay, there's different mechanisms, but it's permanently attached. This was another picture there from France, the Salto itself. Again, this is the mobile bearing. I helped that group write up their series, mostly because I was really good at actually taking English from a French speaker and making it into better English. So I helped revise their paper, but showed good results. We've had also data now coming down the line looking at the mobile bearing. We published our data at intermediate term. We published our data on the Inbone at medium to long term, and both of them did quite well. It's interesting to see, though, that stemmed implant actually has a better survival, and that's been my experience over 7 to 10 years compared to the Salto Talaris. So there's something to be said, but that's for another discussion. Here's the timeline of other implants. Many of these are non-mobile. Okay, so the Zimmer, Infinity, Cadence, Vantage, and as Casey said, Apex and Kinos, those are all the newer implants, and they are non-mobile bearing. I have adapted over time as the implants have come out. I think there's a lot of good options on the market, but I use currently non-mobile bearing. Maybe there's a disclaimer there to give, but I just have good experience with it. I'm going to show some of the data in a second. This is me putting in one of the early Adaptis 3D printed Infinities. So the thought is, in terms of over time with aseptic loosening, if you have polyethylene wear, that it leads to this whole cytokine soup. And I don't even have time or expertise, despite me looking at this thing a million times, to understand exactly how this happens. But polyethylene wear initiates a cytokine response, which activates osteoclasts. And we know that can eat away or take away bone, which leads to implant loosening, subsidence, and cysts. So the idea is if you can limit wear, then you likely can have better long-term outcomes. Now, we still lack some long-term outcomes in terms of total ankle, but we're getting there. Wear has been studied by Steve Haddad and his group. They tested 2 different polyethylene. So part of it depends on the polyethylene itself, but they tested this conventional high molecular weight poly versus a highly cross-linked polysterilizing gas plasma, and basically showed that the highly cross-linked had smaller and rounder particles, presumably going to lead to less inflammatory response and less wear. The people that are that believe in mobile bearing will cite these theories. They say that there's reduced wear debris due to the high congruency on both sides of those implants. You don't have edge loading. This is a picture of edge loading when there's a turn in the implant on the bottom and it wears on one side, although edge wearing can theoretically happen also in mobile bearing. The mobile polyethylene on the flat surface on the top theoretically creates low contact stresses compared to fixed device, although you can have backside wear. And this can also dissipate some of the stresses at the bone implant interface. And here's just an example of an implant that had kind of twisted or turned, rubbed the polyethylene, but that's definitely edge loading. There is some data. Again, that French group compared their fixed bearing version of the Salto, which is the original one they put out, to mobile bearing, which is the Salto Talaris, and basically showed that the AOFAS scores were higher in the fixed bearing than the mobile bearing group, and cysts were less common. So some a very nice ability to compare those, which showed the fixed bearing probably better in that sense. I thought this was fascinating. They took their mobile bearing implants and were able to register the implant from 3D to 2D and made some assumptions about the kinematics, but they could actually get a sense of how much that poly moved in their mobile bearing version. And the truth is it moved very little, from anywhere from 1.5 to 2.3 millimeters. There's been studies on gait in terms of mobile versus non-mobile bearing implants that Robin Queen had done when she was at Duke. There was no statistically or clinically meaningful differences between fixed and mobile bearing implants. I suspect a lot of that's just because it's hard to tease those apart. Here's one that Duke was also able to capitalize on, having had used STAR, which is mobile, versus Salto Talaris, which is fixed, and they saw greater lucency and subsidence and reoperations for the mobile bearing. So you see kind of a pattern in the literature over time that mobile bearing has some more issues. This is a group out of Switzerland that studied also mobile bearing versus non and showed a 3 times higher rate of revision for mobile bearing implants compared with fixed. There's a picture at the AOFAS recently where Andy won, and his team from UK, large team I should say, won the award for best clinical paper. And they were looking at arthrodesis versus ankle replacement. But as part of that, they did this subgroup analysis, which showed that fixed bearing total ankles outperformed ankle fusion, whereas mobile bearings perform worse than ankle fusion at 2 years. So again, maybe there's something to it. If you look at larger registry data in terms of how long these implants last, this one was out of the UK. The 5-year survival for fixed bearing was 94 compared to 89% for mobile bearing. So it just a pattern you continue to see. And because of this, if you follow curves for the implants used in the UK, they're using much more non-mobile bearing implants now. About to finish. I had the chance of going to the Australian-New Zealand meeting last year, and one of our Australian colleagues presented their data from their joint registry from 2015 to 21, looking at fixed versus mobile bearings, and mobile bearings had a significant higher revision rate. So in summary, there's so many implants that have come on the market. Many of them, especially in the US, are fixed, but there's also mobile bearing designs. They all seem to have helped patients in terms of pain. There's theories to support mobile bearing, but really what I would say is, in my experience and the literature, the current evidence supports fixed bearings as having better outcomes. Maybe that's in part why the U.S. market has been more fixed bearings, and the trends in Europe and Australia, and I would suspect the rest of the world are going towards fixed bearing. I'll stop there. Thank you, Annie.
Thank you, Scott. That was a really wonderful talk. I know that you included the last couple of papers looking at the overall trend for mobile bearing having more revision. Do the papers really break down to what type of problems they ran into, like long-term complication, or is it just mostly revision rates?
Yeah, well, so the mobile bearing is there's the one study that shows it's more lucencies and subsidence. And I think that's what's ultimately leading to them failing over time. Now, I guess to be a little bit fair, a lot of those studies are with the STAR, and that's probably also true of the Australian registry. So maybe if there was a greater number of mobile bearing implants available that were improving constantly like we have in the US for the fixed, maybe it'd be a different story. But to answer the question, it's mostly lucencies and subsidence.
Okay. All right, great. Thank you. All right, so we're switching up the orders a little bit. So next up, thank you, Dr. Slovenkai, for joining us from Boston today. Dr. Slovenkai did his residency at University of Massachusetts and fellowship at Medical College of Wisconsin, and he is the chief of foot and ankle division at the New England Baptist in Boston. Thank you, Mark.
Thank you, Annie. Can you hear me?
Yes.
Okay, excellent. Well, and I'd like to thank Dr. Su for inviting me to be on this esteemed panel. It looks like Dr. Schoen has arrived. Welcome, Lou, and hi, Scott. Let me see if I can get this presentation up. And
Excellent.
I need to just minimize this, I think, or just get rid of it completely.
Mark, what the others of us had to do again is because when you have to share the entire, there's that option to share the entire screen.
Okay.
That seems the best way to, and then with your PowerPoint in the full mode, open mode, like that presentation mode, then it tends to show up as a full screen. So when you go to hit share, there's those different options like share one tab, one window.
Okay, let me see.
Do a full entire screen and then put your PowerPoint in the presentation mode.
So I am looking at.
So if you hit share and then go to entire screen, you should be able to pick your PowerPoint.
Okay. I know it seems, so I'm going to slideshow.
Nope. On the platform, the video platform, the virtual platform, hit share and then it'll give you three options. Hit entire screen.
So I am on the video. So I'm looking at the three of us there.
Yeah, there's a share button on the middle bottom, right? Usually right below us.
Got it.
Yeah, and then it should give you options like Celine said of the entire screen.
Got it.
Yeah, and then you just have to make your PowerPoint big.
And is that working?
Yeah, and then can you go to your PowerPoint? We're seeing your whole screen. Oh, that's interesting.
Wow.
That's like a picture within a picture going into infinity.
Hey, Matt, any thoughts to guide?
Yeah, just what they're saying is you want to go share that PowerPoint now. Go to the actual PowerPoint and make that full screen.
There you go.
Do you see anything right now?
Yeah, we can see your PowerPoint. If you just go to make it full screen now with the presentation mode or whatever it's called.
Presentation.
Oh, that's interesting because now it's like you have to almost swap that presentation. There you go. Perfect.
There you go.
Are we in?
Yep.
Okay, fantastic. All right, so I think my charge from Dr. Su and the committee here was to give my experience on the Salto over the years. I have no disclosures relative to this talk, so just wanted to give a quick look at my TAR journey. So I'm one of the old guys here, and it was a new century when Charlie Salzman, he came over to see me at the Leahy Clinic. He gave us a grand rounds on total ankle and Frank Alvine's extensive experience and helped me do my first agility back then. So it was 24 years ago. And we had so much fun putting this external fixator on, as you can see there. And I'm sure everybody's happy they don't have to do that anymore. So I said, okay, I can do this. This doesn't look that bad. The old agility. Well, hold on a second. It's not so easy. And one thing we certainly learned back then was you really need to balance the foot. And if you don't balance the foot, things can go south very quickly, and soon you are taking that implant out. So one of my one of my last agilities was back in 2006. So the patient comes back in 11 years post-op. Here's his agility. He was complaining of weight-bearing pain and gutter impingement, and the CT scan suggested that it might be loose. So we removed the talus a couple of years ago. The tibia was well fixed. I had the rep find some implants somewhere around the country, and we were able to try different ones in there, cemented that into place. So just a quick look at an 18-year follow-up from an agility, and you certainly won't see those around very often. But he was happy that we didn't have to take everything out, so was I, and he didn't have to have a fusion. Well, let's fast forward now to the Salto, which is what I'm going to talk about, developed in France in '97. First with Tournier, then Integra, now with Smith & Nephew. And it came out initially as a mobile bearing in Europe. In the United States, it was a fixed bearing prosthesis, and it was approved in 2006. And the unique thing about the Salto is that it had this tibial keel with excellent coronal stability, which made it a very desirable prosthesis. This is just an example of what it looks like being implanted. The Salto also has a flat top tailor option, as you can see. And also they did come up with a revision system called the Salto XT, otherwise known as the shark fin. So you can keep the talus and put in a tibial revision component. So we took a look at our Saltos from 2007 to 2012. We had 81 ankles in 78 patients, and we found a 97.5% survival rate, which was equivalent to other studies. There was a few others that were also published about that time. Just want to give a shout out to my former fellow and now colleague, Kurt Hoffman, who did a lot of the work on getting this data together. My more recent fellow, Dr. Endo, is now over at Tufts. Looked at our clinical results of that specific cohort, now at a mean of 11 years, and he presented that experience in San Francisco recently at the meeting. So among the initial 78 patients, a total of 16 patients had passed away. 14 patients were lost to follow-up, and the remaining 48 patients were followed for a mean of 11 years. If you look here at the demographics, the mean age of the 48 patients was 64 years at the time of surgery. The most common diagnosis was primary arthritis in 22, followed by post-traumatic arthritis in 21 patients. The mean length of hospital stay was 2 days, with 26% of the cohort discharged on post-op day 1. Looking at the implant survival, after average of 11 years, it was 88%. The most common complication immediate was wound healing problems, followed by bone fracture. And radiographically, 10 ankles had evidence of aseptic loosening, 4 of which remained asymptomatic, and the patients did not desire revision surgery. The remaining 6 patients, however, showed evidence of aseptic loosening, leading to subsidence, and underwent revision. Patients showed good to excellent scores at final follow-up, which were similar to the midterm follow-up that we had previously reported on. Patients showed good to excellent scores at final follow-up. We also took a look at their range of motion, and their range of motion was maintained throughout the follow-up period. We looked at the coronal alignment of the ankle joint, the degree of talar tilt, as well as the degree of sagittal translation of the talus, and we measured all of these components as well. There were significant variations of the preoperative tibial coronal alignment. It ranged from 18 degrees of valgus to 17 degrees of varus, and this improved postoperatively and remained consistent at the final follow-up with a range of 4 degrees of valgus and 5 degrees of varus. The midterm and final component alignments really showed no significant change between the two. Now, the final post-op radiographs did show radiolucency around the implant. We found, looking at our cohort, that on the AP X-ray, zone 2 and 3 on the tibial component had a 67% lucency rate, whereas on the lateral radiograph, zone 6 and 7, or more posteriorly, had up to a 64% lucency rate. So I just wanted to give an example of a few cases. Here's a 52-year-old male who came to me with hemophilia, pretty much had end-stage arthritis of the ankle. The MRI, nothing too specific. It just showed really end-stage arthritis. Bone stock was reasonable. So in 2018, I performed this Salto procedure on him. He did well over the initial period of time. Here's his 2-year post-op routine follow-up. So I started to see a little lucency around the stem of the Salto, but I felt at that time he was asymptomatic. And, could this be stress shielding from that tibial stem? I have seen that occasionally in other patients as well, and really thought it was just stress shielding. Well, we were bringing our patients back at that time at 5-year follow-ups, and now you can see here in 2023 that a sizable periprosthetic cyst has formed that I was concerned about. So we got a CT scan last September, and which did show medial tibial osteolysis and cyst formation. Patient didn't want anything done at that time. We had discussed treatment options, and we decided to get a follow-up CT scan at 6 months. So at 6 months, basically the cyst did get larger, and we both felt that this was now in the realm of potential catastrophic failure. So he is actually booked for bone grafting, ICBMA, and a poly exchange. And I like to think of this as resetting the clock and giving the new implant a chance for survival. And so far, I've had 4 Saltos to date that have done this somewhere between post-op year 5 and 10. So just a few long-term follow-ups, which is what Dr. Sue really wanted me to talk about and show in my cohort of patients. Here's a 58-year-old female. In 2008, I went ahead and put in this Salto with an ipsilateral subtalar fusion. She came in for her 10-year post-op. We were bringing them in at certain intervals. She was doing okay. She had some dorsiflexion issues, some gutter impingement, and was offered a gutter debridement but declined. And as you can see here, the implant is still well fixed and no evidence of lucency or subsidence that I could see on her case. She came back actually 8 years later, just wanted to get her ankle checked out. She was complaining of a little medial impingement pain, but you can see here is a 16-year follow-up of a Salto. The implant, again, continues to be well fixed, no evidence of loosening that I can see, and she continues to function fairly well with just some medial impingement pain. Here's a 67-year-old female with arthritis, and a Salto was placed 10 years ago, 2013. She comes back to see me in 2021. She's now 75 years old, was diagnosed with rheumatoid arthritis. And so this is the x-rays you can see that we have to deal with. I felt that these cysts were of substantial nature, that we could either bone graft them initially and wait, or choose a different prosthesis. So I elected to do the in-bone with her. She had this 2 years ago and did well. And then here she came back at her 1-year follow-up for the in-bone, 10-year follow-up for the Salto, both doing well, and motion very adequate with both prostheses, ambulating well, and pleased with her overall results. This will be interesting to follow long term to see which ankle she actually prefers. Here's another 59-year-old female, implanted Salto in 2013. Post-op x-rays. Here you can see a little bit of that stress shielding. I think about that on that AP Salto x-ray. So 2023, she comes back in. She's got her 10-year follow-up with her left Salto. Her right ankle is starting to bother her. You can see here she's got bone-on-bone arthritis. So at this, here's her range of motion on that 10-year Salto. Again, excellent motion, well-fixed implant, no evidence of loosening or subsidence. So we decided to pivot and we go more modern and ended up doing an Infinity prosthesis on her. So she is now about 6 months out from that prosthesis, again, doing well. Last case is a now 94-year-old male. In 2010, I performed a Salto on his right ankle, came back 6 years later, and we did the Salto on his left ankle. Here he is in 2020. I examined him 4 years ago, 10 years on the right, 4 years on the left. Implant still well fixed, no subsidence, no loosening. Here's his range of motion, which is quite excellent. He's a slow walker, uses a cane, was thrilled to be able to come back and show me that he can still walk effectively. It's a very nice long-term follow-up with his ankle. So in conclusion, overall, the Salto has performed well over time. There's been several studies out in the past several years of mid to long-term results with similar good survival rates, acceptable long-term survival, and low rates of revision and other complications are generally seen. Patient-reported outcomes have revealed excellent long-term results, as well as the preservation of preoperative range of motion. Osteolytic cysts, I am concerned about those, and I do continue to follow them, hoping that with the new and improved polyethylene, that this will be less of an issue. So I want to thank everybody for letting me present our Salto, and we're still reeling in the beauty of the eclipse up here in New England. Thank you.
Thank you so much, Sloke. Scott was asking on the side here a question in terms of follow-up. How often do you follow up these patients in terms of looking for these asymptomatic cysts?
That's a good question. I mean, I think that I have I've typically tried to follow them at the 5-year interval and about the 10-year interval. I've gone on to newer prostheses where I'll follow them for 2 years. And not as frequently, but I'm trying to do 5 and 10 years if we can get the patients back in and be evaluated. I think it's important. It's hard because a lot of these patients are asymptomatic, but like that first case of the 52-year-old hemophiliac, I'm glad we were able to keep an eye on that because I think we're able to avoid a catastrophic failure on some of these. It's not often, as you can see, but some of these do need to be treated down the line.
And the zones that you mentioned before, the different zone where you see the lucency, are there any association with which zone tends to be more symptomatic, or are they pretty fairly asymptomatic?
Yeah, I think they're more asymptomatic. I don't think we've really been able to identify, specific pain with the zones of lucency. The ones that are most concerning, obviously, are the ones on the medial side of the tibial component, where that medial malleolus can get pretty thin.
Okay, great.
Can I make a comment, Annie, too? So I had pretty good experience with that implant too, and Michelle, I think, originally described that stress shielding around the stem, right, Mark, where you'd see the cyst develop around the stem of the keel, which, like you said, is less important because it's not the surface. I don't know if you did something about those particularly.
I'm gonna call that stress shielding because I think of a lot of X-rays that I look like had that, just that little bit of a lucency on either side, and I think it's got to be stress shielding. And it's never really progressed to clear-cut osteolysis.
All right, so in the interest of time, we will move on to our last speaker. Last but not least, Dr. Lushon. He is a director of orthopedics at Mercer Medical Center in Baltimore, and he also is a clinical professor up here in New York at NYU. Thank you so much for joining us, Dr. Schoen.
Thank you. All right, so we should see my presentation, correct?
The kid because you love the mom.
You'll need to bring up that window. We're just currently seeing your current screen.
Okay. I'm going to stop sharing screen. I'm going to share. And when I share,
If you go to share in the entire screen,
allowed to share, window share screen. Okay.
There you go.
go ahead, Matt.
All right, good.
Well, yeah, so when you click entire screen and then click share.
Okay.
And
So-
then bring up your PowerPoint.
All right, so right now I hit stop sharing, right?
Nope. You
No,
just need go to your PowerPoint now.
Got it. Okay.
There you go. And then hit present.
Got it.
There you
All
go.
right, so I'm going to talk about the TM ankle arthroplasty, lateral ankle replacement. Here are my disclosures. I am a co-inventor of the TM ankle arthroplasty, which we wrote the patent over 23 years ago. And now it's in its 11th year of life, 11th year and almost a half. Here are my partners at Mercy Medical Center and at NYU, at Hopkins. And so here's the TM ankle arthroplasty, a lateral ankle replacement. It's done from the lateral side, so a fibular osteotomy is done. Just to go through some quick features from the literature, they were comparing the amount of bone resection across the different systems, and the TM ankle resected the least amount of bone. This was not a study that was part of any of Zimmer's sponsored research. It was an independent study. This was a study done by Amendola and partners. It was in JBJS, looking at risks of blood supply with different ankle replacements, and showed that we had very good features with this replacement, with just a compromise potentially to the perineal artery. This is a study that I participated in, showing a bony support for the total ankle, and basically looking at cadavers and CAT scans and looking at flat resections versus curved resections, and basically showed that we looked at the amount of bone density, resection area, and bone support, and we found that there was better bone density, bone support for a curved resection versus a flat resection. The TM ankle uses trabecular metal, which is made from tantalum. It's a different metal than titanium, and tantalum has different bony ingrowth characteristics. This is from a study. It was an amputation of a patient of Charlie Saltzman. Charlie was amputated for other reasons, not due to the ankle. Specifically, the patient was doing well with the ankle, and just looking at the bony ingrowth in this specimen, you could see the trabecular metal and the bony trabeculae interdigitating with that trabecular metal. This is from that study. So we have high coefficient of friction and really good bone ingrowth with many years of experience. Beyond the 11 years that we had it in the TM ankle, there was another 10 years before that. We looked at wear testing, and with this stress test in a rotational mode, as well as dorsiflexion, plantar flexion, there was much less wear, and relative to conventional poly versus our highly cross-linked polyethylene, the wear was 5 times superior with the highly cross-linked polyethylene. We also had a study, this was by Oliver Schiffer, and this is looking at a analysis of the TM ankle, and basically doing finite element analysis and looking at the plastic to see whether there was risk for a fracture, and basically compared it to a star ankle. And with the star ankle, you could see the high red zones here. With the TM ankle, we had overall uniform stresses with no high areas of pressure, and basically we have not had fracture of the poly, as far as I know, worldwide as of yet. Maybe there is a case out there, but in 11 years we don't have that. I talked about this study. This is a study from Frederic Usueli, who is not a designer, but he's an avid implanter. He may be up to 3,000 of the TM ankles. This was some of his early results. And basically, he had excellent survivorship of the replacement. This was in 2016, so it was about maximum 5-year follow-up, minimum 2-year follow-up, and basically 89 cases, minimum 2-year follow-up. He had 98.9% of implants were free from revision or removal. This was our early study. This was one of the first ones out in 2016. And basically, it was a small study of our 20 patients. We had no fibular non-unions. We had no delayed unions or implant failure noted at the 12 stop. Really, we were looking at early complications. We had 2 complications which were resolved with some treatment, and 2 other ankles underwent secondary surgery for symptomatic fibular hardware with good outcomes. So it was really just a kind of a quick look, but we did have a case where there was a deep infection and we had to do a washout, and the implants were retained. This is a study from Charlie Saltzman in 2018, and Alexei Barge did the study. May he rest in peace. He looked at the TM ankle that Charlie had done minimum 2-year follow-up, and basically a 93% survivorship. He did have 3 revisions of a tibial component due to aseptic loosening. In 10 of the 55 cases, a secondary procedure was performed during follow-up. Mean duration was 26.6 months. No delayed union or non-unions were observed in the fibula. VS went from 7.9 to 1.3, and patients had good range of motion that improved from 22.9 to 40.2. And basically, he had good early results. They did have the cases with the 3 tibial components where they felt there was aseptic loosening. As a result, he more religiously adhered to the original protocol of doing a cementing of the rails, which was on our original protocol. And he started doing that and felt that resolved this problem subsequently. This is a paper in Bone and Joint Journal in a 5-year follow-up study published in April 2022, and looked at Usueli's had 89 patients that they were following from before. We had those results earlier. Basically, 86 patients evaluated at 60, 90 months, 5-year follow-up. Statistically significant improvements with mean AOFAS scores, log scores from 8.5 to 1.5. Physical and mental component scores improved. Radiograph maintained neutral alignment without subsidence. Tibial or talar radiolucency found in 8 patients out of 86, but none of these patients were symptomatic. A 5-year follow-up showed 79 of the implants were free from revision or immediate for implants at risk. They recorded 2 cases, 2.3% of failure for septic loosening, and basically concluded that it was safe with a high survival rate at midterm and with excellent clinical and radiographic results. This is a study done looking at the Australian experience on the Zimmer ankle. 84 patients, follow-up about 2 years, deep infection 2.4%, medical component revision 0%, survivorship of the medical 100%, published last year. And basically, patients were overall somewhat or very satisfied. And here's their Kaplan-Meier survival scores showing very high implant or survival anticipated. This is a interesting protocol that Federico came up with for a fast track protocol for recovery. He did it looking at 163 patients and basically looked at having them do immediate weight bearing, and then on select patients, he had a special program. And with this really aggressive immediate weight bearing program, had deep infection 2.4%, metal component revisions 3%, and survivorship of the metal components 96.9%. A study by this is from Scott Ellis and Jonathan Deland. They looked at their 5-year minimum follow-up, 38 patients. Follow-up was 5-year, deep infection 5.2, metal component revision 7.8, survivorship metal components 92.5. And this was their Kaplan-Meier survival graph. This is from their studies overall, showing good scores and overall good maintenance of scores, although not perfect. It was certainly, I think, to me, a positive study. This is from the Swedish registry of 233 patients looking at the TM ankle, and they had a deep infection rate, minimum 2.2 year follow-up, deep infection rate 1.6, metal component revision 2.5, survivorship of metal components 95%, with a very nice survivorship curve. This is from complications after total ankle replacement with a lateral transfibular approach. And this is 73 patients, followed 3.1 year, deep infection 1.3, metal revision 2.7, survivorship metal components 97.4%. This is from Tuzanen from Finland. He had an early study done, and his study, he had 2 studies, and basically the first study, basically he had between May 2013 and 2017, he had 101 consecutive patients, and basically found 88% reported improved function, 65% were very satisfied with the surgery, and 51% did not report any pain at the end of follow-up period. Their scores were good. There were a lot of additional procedures. So he had almost 37% additional procedures. And he did have a complication rate of 20%. And basically, I had looked at his results early on. He passed away, unfortunately, a lovely human being. But he did not fix his fibula very well. He had a high rate of fibular non-unions, and that was the reason for a lot of his satisfaction in his study. And he just really did a great job with the implant, but not with the fixation of the fibula. Now, then he came out with a second study right before he passed. And this was looking at those same cases, and then looking at CAT scan and looking at radiolucency. So I would say the implant was positioned well. The fibula was definitely an issue, but despite that all, he had the metal component revisions only 2.8%, with follow-up of 3.6 years, and survivorship metal components 97%, and had a very low rate of lucency of the implant. So here is the study. We conclude that the risk of implant osteolysis with the TM ankle is minimum in short-term to mid-term. The anatomic configuration, unique material, surgical technique may all contribute to the TM ankle having a low rate of peri-implant osteolysis. So basically, CAT scan follow-up showing a very little osteolysis. And here was his CAT scans, and you could see some of his osteolysis, but for the most part, it was I thought it was a positive study for a series that was maybe not so optimal. This is the Swedish registry looking at 1,200 total ankle prosthesis, followed up for 20 years. And basically, they looked at different prostheses, Integra mobility, rebalance ECI, TM ankle, and basically, overall, the implants were doing better with the more current designs. You can see survivalships were better, and these were the early implants. You can see were trending down. TM ankle is here, yellow. 4 years, basically flatlining on the Kaplan-Meier is not bad. It is bad in life, but in for this study, this was very good. So looking at their TM ankle results specifically, they had 7 out of the 239 prostheses had been revised, and they found overall prosthesis survival probability of 95% after 3 years. 2 years after surgery, 81% of the answering patients were satisfied or very satisfied with surgery, and patients reported medium, high scores, and basically good satisfaction. So this was a revision-free survivalship, tracking out very nicely. And we did that one, and this is... Okay, this is, we did that one, sorry. Okay, now this is my series. So this is 130 patients. We just finished the data collection. 130 ankles, sorry, 122 patients. Average follow-up of 5.9 years, ranged 5 years to 10.1. These were patients' fleet data, all consented. Average age was 60, about half male, half female. Proms were reported with really high numbers, good numbers, low VAS, pain functional numbers were good. Post-op tibial-pedal range of motion was 17.7 dorsiflexion and 21 plantar flexion, and post-op tibio-talar range of motion. So that's looking more specifically at the tibio-talar motion, was 7.4 and dorsiflexion and 17.3 plantar flexion. We had 26 of these patients had, or 20% had, one zone of lucency out of 12 zones of lucency. So the zones of lucencies are looked at 1, 2, 3, 4, 5, 6 on the tibia, 1, 2, 3, 4, 5, 6 on the talus. So we had one zone of lucency in 20%. 7 had 7 patients, or 5%, had lucency and in 2 zones, and we had none had more than 7 zones of lucency. So no case of cysts, no subsidence, and I'm sorry, I read that wrong. Sorry, 20% had a single zone of lucency out of 12, while 7 had 6 or more. 7 had 6 or more lucencies. So that's a lot. That's 5.4, but it was 7 out of 12. So that's a concern, but it was 5.4%. None had more than 7 zones of lucency. Sorry, I'm sorry I read that wrong. I just put this talk together just a wee while ago. There were no cases of cysts, no subsidence, no septic or aseptic loosening, or no fibular non-unions. Our reoperation rate was high because at an average of around 26.7 months, most commonly removal of fibular hardware and medial gutter debridements in about 13%. So hardware, fibular plates were bulky initially. I've gone to thinner plates, and medial gutters, I've been more aggressive about debriding them initially, but still some of them will have some medial gutter grow some bones. So it's still a problem, but I don't think it's unique to the Zimmer ankle. I think what's unique is the fibular hardware. Usweli does 3 screws. I'm using a thinner plate. Some people are using a fibular rod. I still like a plate because I'm doing aggressive range of motion. So I'm not going to necessarily change it, but the thinner plate is definitely more important. There were 5% case of acute infection treated with IND and metal component retention. I did polyswap on those. Overall implant survival defined by retention of the metal components was 100%.
Lou, I'm sorry. Do we have to wrap up. I was told I should wrap this up.
That's it. Thank you very much.
But thank you. This is very interesting. We have a couple of questions on the side. We'll answer them through text, just in the interest of time.
Thank you guys all for making this session happen. Awesome information, the kind of things that not only the other healthcare providers, but even the public who's joining us needs to hear. So I appreciate it.